and we'll also put the slide deck up. And I believe there's a PDF handout that the social workers have put together. So I wanted to give a bit high level of why we're here, why we're having this conversation. There have been a number, too many to even count, very publicly interactions between law enforcement and someone who is experiencing a moment of emotional distress. And what we're seeing is instances where law enforcement are not handling, not even best, and actually causing significant harm, and in some cases has led to a number of fatalities. Police officers wear many hats, and one of the hats, as you'll hear a little bit in the conversation here, is how the care of individuals who are having an emotional situation has been put on law enforcement, because nowhere else in society are we adequately addressing this. So why are we talking about this here in Maplewood? We, like every other community, have had our own challenges in this particular area. Back in 2007, there was a fatality in the township of Maplewood. A gentleman who was having a mental health crisis at the time, allegedly had a weapon in his hand, and he was shot and killed by two Maplewood police officers. So we are also we ourselves, and we know the number of EDP calls that come in, and other types of calls like domestic violence, which Kasha will speak to next. That's very much part of what's going on here, and thinking of ways more holistically in terms of how we can best serve our residents who are having a health crisis. It may not be a health crisis. So where we may see, where as a community we have through our health department programs helping with diabetes and other types of health matters, our hope in this conversation today is to think through how we can reimagine, and we can really look at how we can better serve our residents who may be experiencing either directly mental health crisis, or the side effects of mental health crisis, whether it be a family member and that impact on them. We wanted to look through different options and looking at models around the country as to what might fit the need here in Maplewood, both in terms of a data perspective, but in terms of our philosophy in the world. We're also hoping this conversation can be a springboard to destigmatize destigmatize access to mental health care and other support services, to make it people realize it's okay. It's not a criminal act to reach out and actually get support of a trained mental health professional to address particular needs. So with that, I'm going to turn it to Kasha, and then we'll talk a little bit about the panel that we'll hear from in a little bit.
All right, so thanks for that setup, Erin. So did you mention the piece about voting and all that at the end?
No, I'll say that very briefly. I'm sorry, I forgot. Just, I have to say, we gotta just, we have to have executive sessions like at the end of meetings. I'm trying to transition my head here. So what our hope is at the end of the day, at the end of the presentation today, is that we as a board can have a conversation and really consider what's been presented, and potentially make a recommendation by voting to the township as to the option that we would hope for us to proceed forward with as a community. And with that, also lending our support by having one or two of our members working with the township in terms of really looking through the feasibility of rolling out a particular plan, whatever we recommend, or whatever they're looking to do if they don't take our recommendation, to be a collaborative partner in that process. So it'll be a two-part vote at the end.
Yeah, I think it's important to understand that, what we're laying out today is sort of a philosophical view of different directions that we could take this. There's obviously an entirely separate conversation about logistics and funding and the realities of the township that we live in. This presentation does not address that. It really just outlines what the various philosophies are. But it's our opinion that if we start from a place of this is the vision that we'd like to create for the community, then sort of a second working group could work in partnership with the township to start answering those subsequent questions about, you know, what it actually starts to look like once you get boots on the ground. Okay, so what are we talking about here? I want to make sure that everybody's grounded in the types of incidents that might warrant a social worker involvement when it comes to police interaction. So there's obviously social work is vast, and I'll tell you, I've had a major education on social work over the last couple of months, thanks to this incredible working group that we have. And their scope of work is humongous. But here we're really focused on the types of incidents where police officers might be called to that could include social workers. So those things include certainly domestic violence, mental and behavioral health crises, neighbor checks. And what we're talking about there is somebody saying like, listen, I'm a little bit worried about what's going on next door. Like they seem, you know, maybe they're hoarders, or like I haven't seen anybody come out, you know, in the last 2 weeks, even though I know that somebody's there, that sort of thing. Certainly substance abuse, homelessness, and other disorderly conduct in public spaces. And then duty to warn, which is, you know, where an officer has to, if they, you know, somebody else will be able to describe this better, but it's basically around, you think somebody might be in danger of harming themselves. And so a social worker might say, okay, I have confidentiality with you, but if I think you're going to harm yourself, then I have a duty to warn, you know, the appropriate authority that, you know, they might endanger themselves or others. And there are a handful of other things that fall under this, but this is really the scope that we're talking about. So then, of course, we have to then take the lens onto Maplewood, because we are our own township, and we have our own issues. Some are greater than others. And now this data, don't take this as gospel, because some of this is easy for us to pull from the police department. Some of this is not as easy to pull because we don't have everything sort of perfectly, we don't collect all of this in a perfect way. So, but I think that, you know, rather than taking the numbers, the hard numbers as fact, what I would do is just look at the scale of what we're talking about. And what we see is that, you know, majority of issues in Maplewood include domestic violence, emotionally disturbed persons, and then neighbor checks. Now, the nature of these neighbor checks, you know, there's a wide variety of these, so I wouldn't assume that all of these would involve a social worker call, but nonetheless, you know, you can see that we're talking about hundreds of these. When it comes to drug possession and overdose, then we start talking about single digits. You can see homeless persons. Okay, there are 2 incidents recorded in 2019 for homeless person calls. Suspicion is that there are probably many more calls than that. It's just that depending on how it gets recorded, it might not get recorded as a homeless person. So again, you know, don't take it all as gospel, but hopefully this gives you a sense of the scope of what we're talking about. All right, so from there, I'm going to hand it over to one of our social workers. Okay, and you are, by the way, Glenn, I made Nina a co-host because she's running the presentation. So FYI, that's why she's able to do it. So.
Hi guys, so just want to lay out for you, what are the different components of this presentation tonight. So we're going to start with a little bit of a discussion on the scope of social work so you can kind of understand our different roles. I'll introduce everybody who's been working as a part of this working group and who will be presenting tonight. But we're also going to dive into trauma and how it applies to law enforcement and police departments, as well as the history of deinstitutionalization and this conversation regarding divest and invest. And then we'll get to the 3 models that we're proposing for you guys to consider. It's really important for us to do that foundational conversation around trauma and history of deinstitutionalization so that you guys can understand where we've been and where we're going. So we're going to talk a little bit about social work. You guys didn't know that you were coming to graduate school, but welcome to my class. So what is social work? Social workers work on a variety of different things at a variety of different levels. At a micro level, you have direct practice workers. Those might be therapists, they might be case managers, they might be working with individuals and families. You also have social workers who work on a meso level, and those are social workers who work who run whole programs, directors of agencies. They work with organizational change and change management. And then you have macro social workers who work for large scale policy, right? Thinking about state or federal government, or even like the United Nations, social workers who are really doing large advocacy and advocating for large system change. And then even within those three levels, you have social workers who specialize in certain populations, such as aging, family and youth, school-based, health, mental health, right? You have hospital social workers, you have treatment social workers who specialize in LGBTQIA needs, criminal justice social workers at the prisons and different things like that, and then other special populations. We also just want to point out to you that over 70% of mental health services in the United States are provided by social workers. A lot of times when people hear social work, they think of like DIFIS or Child Protective Services or case management. But social workers, really, you often won't know who's a social worker sometimes. We are in a variety of different settings. And something that makes social work unique is this concept of person and environment. Person and environment is foundational to social work training, and it really helps us understand not just looking at the person's behavior and their specific needs, but also looking at them within their environment, within the context. We look at both together. Some other specialties, like a medical professional, may just look at what are your blood levels, what's your heart rate, all of those things, and they're just looking at the person. Some other specialties may look at just the environment, but social workers, we really are a holistic approach that looks at all of that. So I want to introduce our panel to you guys. So I'm Nina Essel. I am a licensed social worker. I also have my master's in education. I'm a school-based social worker by trade. I've been doing that for over 10 years, and I specialize in crisis de-escalation with youth and families. We also have Heather, who's a clinical therapist and a trauma specialist. Blue, who is a clinical social worker currently in private practice, but also has a history of working in mental health clinics and with the mentally ill. Jessie is a direct practice social worker. She's a case manager at acute rehabilitation and has a specialty in traumatic brain injury. Sharon is an organizational data outcomes and policy leader at a large local nonprofit that services New Jersey. And Kelly Quirk, who isn't here speaking with us tonight, but has been a very integral part of this working group, has organizational management with significant experience with homelessness, severe mentally ill, and substance use disorders. So those are the different people that you are going to be hearing tonight and who we've been a part of this working group to put together these specialties. And I'm going to pass it to Heather to talk a little bit about trauma.
Hello, I'm Heather Hers. I'm a clinical social worker in private practice currently, and before that I was in a community mental health program and school-based health clinic in the city, and I specialize in trauma treatment. So I'm going to talk for just a couple minutes really quick. It obviously could go much longer, but we're going to keep it short about trauma. Why is this important? I think in working with vulnerable populations, as social workers do, we're encountering people who may be suffering the effects of a trauma. And this is relevant when we're talking about law enforcement encounters as well. And what we're looking for is to have encounters be as trauma informed as possible. So what is trauma? You know, the textbook definition is here. We're talking about symptoms or effects of an incident, and it can include direct or indirect exposure to death, threatened death, actual or threatened serious injury, actual or threatened sexual violence. I think it's important to note that witnessing an event can also be traumatic rather than just experiencing it directly. And also that a threat of violence can be traumatic even if no one ends up being harmed. So someone can have certain risk factors or protective factors to developing trauma, but we don't really know how somebody is going to respond. So two people can have very different reactions and abilities to cope to the same event. So what happens in the nervous system when there is a threat perceived? You may have heard of fight, flight, freeze response. This comes from evolution. So basically our ancestors, cave people running away from the saber-toothed tiger, we still have some of those same reactions. So the system is orienting to try to deal with the danger. And you see that picture of the brain, the red part in the middle there is the amygdala, which is in the limbic system. And that is like a smoke alarm that goes off. Slide. So in this picture, you can see what happens to the body during a fight, flight, or freeze response. Stress hormones are basically readying the system for action. And what happens is that the more sophisticated thinking part of the brain, which is called the prefrontal cortex, shuts down so that we're left with the more primitive part of the brain in charge. So if you're watching somebody, this can look like either like an activated state, a panic state, or agitation, or it can actually look like the opposite, which would be like somebody who is numbed out or dissociated. Speech or concentration might be impaired. And the reason I point to that is that somebody could be perceived in an incident as being non-compliant or resisting when actually there's a trauma response going on. So I think that's important to understand. Slide. So some traumas are like a single incident, such as an accident, car accident, something like that. But a lot of the times what's happening is that people are dealing with chronic trauma, and that a previous trauma can put someone at risk for developing symptoms later on if something else happens. This chart here, is from a study that talks about all the different possible negative outcomes to repeated traumas that can affect someone's health, mental health, behavior, substance use, etc. And what's happening biologically in the system is that the stress hormones, like cortisol, are continually activated so that someone is constantly in that fight, flight, freeze state. That smoke alarm that I talked about is going off all the time, even when it doesn't need to be. And then I also wanted to note that trauma can interfere with someone's appropriate ability to make meaning of an event and to actually sort of form their identity. Slide. So what can we do? Why is this important? We want trauma-informed intervention from first responders.
I'm sorry, just a quick question on the last slide. Has there been any study around like this trauma from like a racial perspective, or even in terms of like repeated viewings of like race-related traumatic experiences?
Yeah, I wrote about that in the next slide a bit. That's also, I want people to be looking at community trauma, racial trauma. I think it's here somewhere. Yeah, disproportionate, law enforcement encounters among people of color. George Patterson, who you will hear about later on, talks about like internalized criminalization of how this can impact someone's, just sense of self-worth and meaning of the events. And all of these sort of go together as risk factors for further trauma reactions. Repeated encounters with law enforcement can certainly have an effect on somebody's, sense of themselves. Hopefully that answers the question a bit. So what are we looking for? Trained staff who can support people to return to that baseline functioning. So in other words, turning off that fight, flight, freeze response and re-engaging the thinking part of the brain. That can include somebody who has a calm demeanor, non-threatening posture, soft voice, speaking in simple phrases, checking in and giving physical space, so that we're getting people back to baseline. Building trust and positive associations that will not trigger that nervous system response. Awareness of impact on certain populations, as you spoke to, and increasing community supports to reduce the reliance on emergency calls so that it's more of a preventative approach, so we're not getting to the emergency level to begin with.
Just want to add that racial trauma is definitely something that's being studied more and more. And it doesn't have to be like an acute one-time incident, like someone called you a slur or physically attacked you. Racial trauma can also be just the stress of living in a world that doesn't value you, that doesn't see you as human, where there's a lot of microaggressions and things like that. So sometimes people don't even necessarily know that they're experiencing racial trauma because they're just not aware, because it's all these little minuscule things that add up over time. And you'll also see, like, we all have a fight, flight, freeze response. We all have that like rapid heartbeat. We feel the tension or the pressure in when we get emotionally dysregulated. So every single person has the ability to go into fight, flight, freeze. What you will see for some people, especially who people live in like constantly stress environment, chronic stress or toxic stress, they just have cortisol pumping through their bodies all the time. So chronic poverty, violence in the community, right? Even if something hasn't happened to them physically, because it happens around them or they're stressed about it, they can also have an overactive amygdala and an overactive fight, flight, freeze response that can lead to the things that Heather was speaking to. pass it off to Blue.
Sorry, I don't know how to unmute myself. Thank you, whoever unmuted me. Hi, I'm Blue Chevigny, and I'm a therapist and also worked for a long time in community mental health around housing of homeless mentally ill people. And I wanted to help contextualize this presentation and the proposed changes that we're proposing tonight in terms of the history of how it is that we have some of the public health and safety issues we have today, and how it is that these concerns have moved into the purview of the police and criminal justice systems. The history of deinstitutionalization of quote unquote insane asylums started in the 1960s and continued through the 70s and 80s. It came out of a movement that grew out of the civil rights movement and led to many cases that went to the Supreme Court. And eventually the law of the land became that patients in these institutions had the right to treatment in the least restrictive environment possible. And it was recognized by society at that point that it was inhumane to be doing what we were doing, which was keeping people locked up for being mentally ill. So this closing of mental institutions was a good idea because the institutions were a broken system. But what did not happen in a systematic way once they were closed was the creation of community-based programs and solutions to replace them. So there was poor implementation of this good idea. And there were several things that caused this not to happen. One was that the community wasn't prepared to absorb these released patients and meet their needs. And there was a social stigma attached to mental illness that led to an unwillingness on the part of many communities to welcome these new members, a sort of not in my backyard NIMBY phenomenon. There was a lack of widespread understanding and knowledge of what was best for former patients in the community and what services were needed and what level of support. And perhaps most importantly, there was a lack of funding and political will on the part of the federal and state governments to prioritize the vast needs of this giant population of people. Next slide. So what does all this have to do with the police? So what happened was that the criminal justice system became the catch-all system. While underfunded community-based social service and mental health agencies were created and scrambling to invent and implement what was needed for people in mental health after these asylums closed, simultaneously in the 80s, there was the housing boom happening and the concept of low-income housing, a lot of which was like single room occupancies and things like that, where a lot of people who were living in the margins of society had ended up, many of them formerly institutionalized. Those kinds of housing diminished in number to the point of being almost eliminated completely, leading to greater wealth gaps and higher than ever rates of homelessness in the United States. So people who could have used mental health services or low-income housing ended up homeless. People who could have used mental health services ended up untreated and sometimes involved in domestic disputes and interpersonal violence. People who could have used mental health services ended up untreated and self-medicating and thus living with substance addictions of various kinds, which at times can be connected to breaking the law and being disruptive to the public. And a lot of these social ills occurred in the public space and came to the attention of people in the public, and they would reach out for help. And who did they call? The police. So the police end up fielding the calls for these kinds of situations and handling matters pertaining to all levels of mental health and other social service needs when they were more accustomed previously to dealing with traditional crimes. So simply being mentally ill or having the characteristics of a mentally ill person began to be seen as criminal in this kind of post-asylum climate. Bizarre behaviors, suspicious behaviors, these can easily be seen as threatening or deviant, whether they are or not, because they may be unfamiliar, and because we have, as a society, have come to make the connection and the association between mental illness and criminality. This association exists for law enforcement professionals as well, because they're also part of society and socialized along with the rest of us. And in fact, symptomatic mentally ill people are more likely to be arrested than a non-mentally ill person committing the same crime. At least 1 in 4 people who go to jail are arrested again within the same year. And those are most often people dealing with chronic issues like poverty, mental illness, and substance abuse disorders, the kinds of problems which only exacerbate with incarceration. And approximately, depending on what study you're reading, 25 to 50% of inmates and inmates in jails and state prisons have a serious mental illness. That's just the people who've been diagnosed. And thus, we're looking at somewhere between 500,000 and 900,000 people in jails and state prisons with mental illness. And in 1955, when they closed the institutions, there were 560,000 people incarcerated in mental institutions. So we've effectively transferred the population from one form of incarceration to another. So entry into the criminal justice system starts with the police, and there are many people in the criminal justice system who don't need to be there. No amount of training of the police can fully reconcile all the things that they're asked to do. And, they're just driving too many cars in too many lanes. Next slide. So we're talking about trying to divide up some of this among the police and social workers. Police end up with too many responsibilities and are stretched too thin to do a great job in any area. They need more help, and they need to have some of the work that's become their domain taken off their plates. Those with social service needs who are interacting with the police over and over again are not only not being served well, they may be being re-traumatized, as Heather said, by the experience of repeated interactions with police, and might really be able to get more of what they need from someone without a law enforcement lens. And we believe social workers can and should fill in the gap. Next slide. Social workers are trained professionals and experts at handling many of the situations that have fallen to the police. In general, social workers are skilled at seeing the whole person and meeting the person where they are at, de-escalating high agitation, high intensity, high conflict situations, problem solving in a holistic manner. For example, looking at the interconnected web of systems at play for an individual, engaging with people with compassion and from a non-punitive starting place, recognizing trauma reactions like the ones Heather described and how to manage and alleviate them, having knowledge of and experience with a range of mental health disorders and atypical behaviors and how to approach people exhibiting those behaviors safely, then connect them to services for long-term treatment. Social workers have been using trial and error from before deinstitutionalization and ever since to design and implement programming that's optimal for delivering meaningful assistance to people suffering from mental illness, substance addiction, and perpetrating or suffering from interpersonal violence, the things that land them so often on the streets or in the hands of the police and criminal justice system. We've tried the models for treatment and we know what works and what doesn't. This is why around the country, the point of view and hands-on work of social workers is being called for as it's the most relevant and necessary to create change within law enforcement. It's been the missing ingredient. And looking at those who come to the attention of the police from a strengths perspective, we allow for the possibility that there may be another way to approach them and help them. And we can bridge gaps and create linkages to services. Next slide. So we're talking about community mental health and wellness. We have multiple models for collaboration between police and social work that are being implemented around the country that we're drawing everything we're about to present from. And the goal of making these changes is for our community to thrive. Everyone wins. Social workers use their skills for community wellness and health, and community members in need get access to what they need. Social workers will be able to identify needs before they rise to the level of where police need to be contacted using a prevention approach. Police would no longer be solely responsible for all the situations they're called on to deal with, thus reducing the risk of unnecessary escalation. So we can provide a more humane way to exist as a community and break the cycle of criminalizing and locking up people who might not need to be. There's no reason not to be at the vanguard of this work to protect our community in a community like Maplewood, where the police and leadership have already been thinking about these kinds of changes and solutions. So we know how to do this better and we should. Thank you.
So as Blue said, we're talking about community health and wellness, right? And community health and wellness is at stake. We're talking about shifting the model from law and order and reactive responses alone to community health and wellness and a proactive and preventative care model, where social workers, when they're integrated, can create community health and wellness by being proactive first and responsive when necessary. And so our models will talk about that in a few different ways. So social workers are involved in addressing specific community needs by solving for specific questions. So we're going to pose 3 community safety related questions to you, and each model that we talk about will address one of these questions. So the first question, which will be model 1, is how can we make police response to mental health crisis, DV calls, homeless conditions, and substance use calls more appropriate and less risky for residents? Model 2 will address how can we redirect calls from police that could be best handled by mental health professionals, paraprofessional, or EMTs. And then model 3 will address how can we use preventative measures to reduce the need for police to respond to the crisis situation.
I just want to pause here before before you go on to explain sort of what the logic models do and what we're doing here. For the board, as we stated at the beginning, the goal is for us to listen to all of this, take all of this information in, have a healthy discussion about the vision that we have for our community and how we can use, different services to handle different needs that we have in the community. It really comes down to answering one of these 3 questions, and which of these 3 questions do we think we should be answering as a community. So I don't want to sort of go too quickly over this, and it'll become apparent as we go through the 3 models, how each of these are relevant, but I just want everyone on the board to kind of bookmark this in your mind. This is where we're going. Is it about, the police and sort of helping them within the department? Is it about, redirecting calls from the police, or are we talking more about prevention is what it boils down to. So again, just to get everybody's heads in the right headspace. Okay.
Thank you, Kasha. And we will send you along with the PDF. We have a lengthy literature review. So should you guys want to dive in and look around, it's where we pulled some of this from. That will be provided to you as well. So going back to social work school, this is a logic model. It is exactly what it sounds like. It is a logical model that we use to plan for programs. Because we're doing it in presentation format, we're going to present more in a graphic style. But if you saw it on paper and in the ones you'll get in PDF, they're laid out just like this. This is not a predictive measure. I just want to be really, really clear. Logic models do not say 1 + 1 always equals 2. Right? We're looking at, by conducting a literature review and what other people have done in other communities and using our best clinical judgment, we're making some predictions. If we put this in and we do this and we have this activity, this is what we predict our outcomes will be. And so when we're thinking about the programs and the models that we're presenting, we thought about all of these things. We're talking about the community, the question that we are just asked to solve. Who are the stakeholders? What are we proposing to do? What is the goal? And then we look at it across 6 domains. What are the objectives, the resources that will be needed, the activities that the resources will be doing, the outputs, and then the short-term and long-term outcomes. There are a few shared assumptions across all of our models. And with an eye toward intervention design, we've developed the 3 logic models that we'll use to address. Most of the following logic models assume a pilot phase because 24/7 coverage would require 4.2 FTE. So that would be 4+ employees just to cover 1 role for 1 shift for 24/7 coverage. So one of the things that we will be talking about is the possibility of adjusting based on shifts. So one of the things we noticed in the literature review and just data in general is that a lot of the calls tend to come in after business hours because a lot of the other resources that they may access might not be open after 5 p.m. So we're seeing a lot in that 3rd shift, like that 3 to 11 shift. And so during a pilot phase, you may want to think about staffing for that shift and then not necessarily having staff 24/7. 2 of our models require a trained 911 dispatcher. We're also going to be talking about educating the community regarding available resources. A peer specialist, which is someone who has lived through recovery and then has gone through extensive training in order to use their lived experience to help someone else. And then with social workers, we also always have to talk about supervision. You have role supervision or task supervision that can be handled by the hosting agency, whether that's the police department, EMTs or a health department, but then the person would also need clinical supervision. This is something that's very, very important to social workers, to have supervision by someone who is also trained in your field when you're working in that. And the other things that we'll be talking about is that all of the models will address these different types of calls: mental health crisis, substance use disorders, domestic violence calls, and quality of life calls such as drinking in the park, homeless individuals, noise complaints, etc. I'm going to pass it off to Jessie, who is going to introduce and walk us through model number 1.
Thanks. So model 1 we're going to be talking about is a social worker embedded within the police department. So someone who is hired by the department, is there on site, and is, really part of that work that's done in the police department. So the question that we're looking to answer with this model is, how can we make police response to mental health crisis calls, domestic violence calls, homeless conditions, and substance use calls more appropriate and less risky for residents? So this proposal is going to be 1 or 2 social workers that are embedded in the department. They're going to go out on calls to assist on crisis calls. They can provide follow-up services and referrals to community members as needed, and do some training also in mental health first aid in the department, as well as with the community at large. Stakeholders here are going to be basically the whole community and the police department, the officers, everyone involved. Next. So the overall goal of this model is we're going to look for a reduction in repeat crisis calls and referrals to appropriate services. So if you think back to the numbers that Kasia presented earlier, there were, over 200 something domestic violence calls within Maplewood in the 2019. But if you do the math, it was like 7 calls from 25 households or something like that. So the idea being that really getting those families connected with services so those repeat calls don't happen. Increasing connection to appropriate services and community, strengthening connections with with community organizations that are already in communication with the police and the community. Some of the resources we need: the social workers, there's going to be tech resources, cell phones, desks, things like that. Investment in mental health training, trainings that they can do with the department or the community at large, and supervision as well. We're going to talk about activities later. Let's go next, please. So some of the outputs, again, the reduction in the crisis calls, and identifying further needs that can be addressed by a social worker. And, short-term outcomes, we're going to hope for, identifying those households that can benefit from services, training officers on mental health first aid. And some of the long-term stuff, we're going to look at the overall reduction of crisis calls, kind of being headed off with appropriate referrals. Next. So some of the strengths of this model are going to be access to departmental resources, right? That person is going to be present at shift change, at roll call. They're going to have the information on what's going on in the department and policing in the community, and really sort of have their finger on the pulse of things. Going back to that role strain that Blue was talking about earlier, we're going to alleviate a lot of that by taking some of that non-police work responsibility off of the officers. There's a presence of a police officer for safety if necessary on those calls. And you can have the social worker as a guide for change within the department, really helping the police officers get a better understanding of different ways to de-escalate a situation and sort of change that culture of how they're addressing community members. There are a lot of concerns with this model also. One of the biggest ones is going to be how does that social worker build trust, right? If that worker arrives with an armed officer, that they may be seen just as sort of an arm of law enforcement, and someone who's in crisis, who has maybe been repeatedly traumatized by ongoing interaction with police, may have a very difficult time finding themselves able to trust this social worker who's there. That could be a big concern. Over and over again in the literature that we reviewed, we came across this idea of a social worker navigating within the police department and how much energy and resources that takes in terms of time, basically navigating within this paramilitary host organization. So social work values and police culture don't align all that well. You know, a social worker is looking at the person and environment. They are taking a strengths-based approach. What strengths do these people, this community member have that can address the problem that they're facing? They're meeting the client where they are and really, you know, coming with compassion and trusting that that person is the expert in their own experience and in their own life. That may really conflict with a culture that is really based on chain of command and law and order, compliance, a punitive system, you know, that relies on maybe an aggressive approach or a toughness that's inherent in that role. And so the social worker really navigating within that world and trying to align social work with that culture might be very, very challenging. Also, there could be a lot of role overlap that could lead to confusion or even competition. You know, a lot of what we read and learned about really highlighted this idea that there really has to be complete buy-in from every level, from the rank and file, from the police unions, from the command, to understand what the social worker's role is and not find any resentment or feeling like something that the police have been doing is being taken away from them. Next. Some of the remaining questions for this model are, you know, sometimes it's been put forward that that person could be a mental health support for members of the department, which really is a very clear conflict of interest. That's a role that's much better served by an employee assistance program, an outside counselor of some kind, maybe. You know, what is the HIPAA responsibility within this partnership? Social worker is bound by confidentiality. So what are they sharing with the officer who responds to this call with them, you know, once they've talked to the person going through the crisis? Nina talked about the clinical role and clinical supervision and role supervision. It's really best practice that there be clinical supervision for every social worker who's delivering this kind of service. And then finally, where in the organizational chart is this social worker going to fall? You know, you want them to be in a position where they're very clearly an integral part of the department, where they are, you know, not an afterthought. But if they are reporting to someone who's very high up, that might create conflict or resentment, you know, maybe from the officers who feel like they've kind of come in and maybe just come in a place where they don't understand how things work. So the last thing I just want to touch on here, George Patterson is one of the leading experts on social workers embedded in police departments. We did a lot of reading of his research and work, and this, I pulled this quote out of one of his articles. It says, the most important skills required by police social workers are the ability to understand law enforcement culture, procedures, and general orders, function effectively within a paramilitary law enforcement environment, and establish and maintain rapport with police officers and a diverse community. It's incredibly telling that the only words in that little paragraph that address the community members that they're serving are the last two words. Everything else is about existing and working in that culture and environment. And I think that's something that, you know, should be thought about a lot when considering this model, that there's going to be a lot of that social worker's time and resources devoted to that part of the job. And that's all I have for that model.
Thank you. So now I'm going to walk us through model 2, which is the crisis outreach team model. So in this model, again, we're starting with a question, which is how can we redirect calls from police that could be best handled by mental health and paraprofessionals?
I'm sorry, can I stop you for a second?
Mm-hmm.
Are we going to go through the 3 models and then go back to each one individually to address them?
Yeah, so we're going to go through, we're going to have the social workers complete our panel of experts of social works complete, and then we'll go back through the different models.
Okay, thank you.
Mm-hmm.
So in this model, we're talking about embedding a social worker and possibly a peer specialist, which again, I said was somebody who has lived experience, someone who has recovered from substance use or is in recovery from substance use and is then using their lived experience to support others. But embed them with an EMT under the health department. So this would redivert 911 calls away from police to a crisis outreach team. And this would allow police to not be to be solely responsible for engaging, right? So they're not always just the first responders or responsible for managing these types of situations. Stakeholders in this model would be the community at large, community members in need of crisis service, as well as the police department, EMTs, and township. And this could be a shared service. This is a model, if you guys have heard of Cahoots out in Oregon, that started in 1989, has been a very successful model out there, and they've seen a lot of progress. And we'll talk a little bit more about that data a little bit later. So within this model, some of our objectives, very similar to model 1, is just to reduce repeat mental health and crisis calls, but also increase community understanding of mental health services and connection to services, outreach to homeless individuals or community members struggling, and increase connection to community supports. This would, in the pilot phase, be 1 to 2 social workers plus maybe a peer specialist paired up with an EMT, so they would work in teams. And obviously they would need different tech and resources associated with that. Some of the activities this person may engage in is reviewing data for repeat crisis calls and conducting needs assessments so they can adjust their programming and responses, respond to quality of life in crisis calls, either before or with police, and collaborate to ensure that the response is least restrictive and safe for that individual, as well as regular outreach to individuals who are in crisis. So a lot of times we wait until that 911 call comes through or until someone is in crisis. And if we can reach out to those, in the data Kasha shared in the beginning, we had 29 households with repeated calls for domestic violence. We already know who some of those families are. And if we can be doing some regular outreach, checking in on them, we could potentially prevent some of the 911 calls before they even happen, as well as providing community training on mental health first aid, Narcan, understanding homelessness, and things like that. So there's also some community awareness components. Some of the outputs that we might see, right, where we can count the reduction in repeat calls, crisis calls, we can measure that. We can count the number of connections that referrals have been made to community services, and we can see the reduction in police response to quality of life complaints. Some of our short and long-term goals are really, again, just going to be about reducing the referrals to police, making sure that these community members are connected to appropriate services, and not just that the connection is made, but that they stay connected. A lot of times with individuals and families who have chronic issues and major issues, they need more case management and they need more support, right? We connect them to a service, but they don't always follow through on that second or third appointment. They might just go to the first. So having that follow-up component is really, really important in addition to the immediate rapid response. So some of the key takeaways here, again, we're focusing on in the moment response and follow-up. That's something that's different than the first model, which may not necessarily do as much follow-up and support after the fact. So some of the pros are we still having in-person response. It could be a shared service between the 2 towns and would work alongside the police department, but would not necessarily be embedded within the police department. One thing this model doesn't address is it doesn't necessarily address the culture within the police department or specific training needs of police officers the way an embedded social worker might. Some other things that we may, consider is that you need to review with legal regarding the dispatch, as this might be a redivert away from police. There's also HIPAA responsibility, and again, clinical supervision versus rule supervision is something that's going to come up in all of these models. And then we have model number 3, which is a community wellness social worker, which is a little bit different than the other models that we've talked about so far, but we really wanted to give you guys a wide range of options so that, again, like Kasha said, you could sit down and think about what is the need in our community, what problem are we trying to solve, and which model do we think will best fit that need. So here we're talking about how can we use preventative measures to reduce the need for police to respond to crisis situations. And we're talking about placing a community wellness social worker within the health department. So this is not someone who's embedded within a first response unit. And they would focus on community level change work and not necessarily just individual level case management. And for this, there's even more stakeholders. We're talking about the community at large, the police department, EMTs, fires, and also school. right? Schools, we can identify a lot of families who may need certain things that we could stabilize families and reduce some of these calls by addressing some of their needs. So, and then there would also be like additional agencies or organizations within our community. So here we're looking at improved community wellness and reduction in referral to police for crisis needs through prevention. So this model is really looking at preventing 911 calls point blank. So there'd be an ongoing assessment of community mental health needs, substance use disorders, violence prevention needs, increased community understanding of mental health service, and lots of training for community stakeholders, police, EMTs, school social workers regarding mental health first aid, suicide prevention, domestic violence prevention, dating violence prevention, right? Doing those kind of awareness campaigns and education that communities often need. This could potentially be a one social worker, LSW background with community-based work background. This would not necessarily, because it's not a rapid response model, doesn't necessarily have to be someone that's staffed, a role that's staffed 24/7. And it could be more of a 9 to 5, typical workday type schedule. And things that they might be doing would be, again, conducting needs assessment. You're going to see that across all the models because we can't plan programs if we don't know what our specific community needs are. Designing awareness campaigns and sharing existing resources, and also doing outreach to micro pockets of the community. So this might be doing some door knocking, walking through neighborhoods, going to churches, checking in with stakeholders and building those relationships so that this person can be a trusted community member or resource for families. Because we know that in order to service families as a social worker, we really have to first work on building trust and building that relationship with the families that we're working with. So what were some of the direct outputs you'd see? You'd immediately see some redirection of crisis calls from police to existing mobile crisis. So we wouldn't necessarily see them, police having to call Clara Moss and things like that. You would also notice that the community connection to strong treatment related programs. So this individual could be building partnerships and collaborations and pipelines so that when we have a community member who's identified as having a need, we already have a relationship, a referral is made, the connection is made. It's not like call a random number on a website and try to figure out if you can get in, because this person would already have those direct contacts to those agencies. And a reduction in the need for crisis calls because we're just being more proactive and more preventative. So we're, again, looking at reducing the referral for police assistance in 20% or less of cases, identifying households that are in crisis or need stabilization support, and being proactive with outreach, and identifying solid community partnerships. So some of the pros and cons of this model, again, this is a very prevention and case management based model to prevent interaction or the need for law enforcement in the first place. It's focused on community health and wellness. Pros are the ongoing case management. Again, like we discussed, a lot of these families who have chronic issues and chronic needs really need that like specific support person. Something I do a lot as a school-based social worker. I have to be like, hey, did you go to that appointment? Oh, let me know how it goes, right? All of that follow-up that can be very time consuming, but if we don't do it, they end up not following through on their supports that they need. Again, improve community wellness because we're doing those awareness campaigns around like Narcan, suicide prevention. These could be workshops or things that are open to the entire community just to build up everybody's knowledge and understanding and education for the community. This does not address the culture within the police department directly the same way an embedded social worker would. And then this model also does not have the rapid response that Model 1 and Model 2 have. So it would be more of a prevention model. So remaining questions when it comes to this model is how are we providing rapid response for crisis calls? Because that's not addressed in this model. And then also how do we identify individuals without violating confidentiality? In Model 1 and Model 2, they're both embedded in a first responder unit. So they would be a part of that team that's responding versus here it would be somebody embedded in a health department. And so how would communication flow? What are the HIPAA laws and regulations regarding sharing information and things like that? I'm going to pass it to Sharon.
Thank you, Nina. Hi, everybody. Good evening. I'm Sharon McCaffrey, and I'm in administration at a social service agency in East Orange. So I just wanted to, now that you've heard about the models, just give you a little bit of a taste of some of the impacts that have happened across the country with some of the programs that we researched. So there was a study in 2016 that estimated that 20 to 50% of fatal encounters with law enforcement involved individuals with a mental illness. So as we were talking about with the institutionalization and things that have happened, you know, folks with mental illness don't necessarily fare very well when they have interactions with police. And the CAHOOTS model, which has been mentioned a couple of times in Eugene and Springfield, Oregon, where calls that come into 911, they're assessed and some are diverted to CAHOOTS as opposed to going directly to the police department. Looking at their example, so in 2019, there were 24,000 CAHOOTS calls and only 150 times were police backup requested. So for the 23,850 others, the agency, the White Clinic that runs the CAHOOT program, was able to handle those calls. And so it's an example of how you're just decreasing the opportunities for these individuals with mental illness to have these negative encounters because they're being handled by social workers and other mental health experts. And another interesting statistic that we found was about a program in Memphis where the police have been involving social workers since 1987. There actually has been a 97% increase in calls from folks with mental illness, while injuries to those individuals decreased by 40%. So here's an example of where the connection has been made with people in the community who need help, who are looking for help, and they are finding help. And at the same time, the negative impacts are decreasing both for the police department and for the individuals. So we just wanted to highlight some of those. Next slide. Here's a little bit, just a graph to take a quick look at the financial impact in Eugene, Oregon, where the CAHOOTS program has been in place. So the CAHOOTS budget is $2.1 million annually. The combination of the Eugene and Springfield Police Department's annual budget are $90 million. They have estimated that the city of Eugene has been estimated $8.5 million a year by engaging the services of CAHOOTS. The work that they do is less expensive per event, and the more events that they've been able to take over, the more the town has been able to be saved, which, you know, is not the ultimate goal here, but it's important to realize that it's part of the equation. Next slide. So to sum up some of the outcomes that kind of are across all of the models that we talked about, we're really looking at a reduced repeat crisis calls from the same household. You know, that's a chronic problem. And by engaging social workers, there's a very good likelihood that we can decrease those numbers. We're going to reduce number of hospitalizations as, you know, mental health professionals can go in there and de-escalate folks and keep them from going into the hospital. That's good all around. Reduced arrests, reduced number of individuals entering the system, right? If we can do the prevention work and deal with whatever's happening in the moment, it's a greater chance that we're going to be able to keep folks out of the system. Reduce incidents, use of force, if we can find other more productive ways to help, you know, particularly with folks who have a trauma history, who may not be acting in a way that feels safe to others, but if we have someone in there who knows how to talk them and de-escalate them, then there's less chance of use of force. And then, of course, increased links to proper supports and service providers. You know, we're going to be identifying those people, meeting those people where they're at, and finding resources for them to help them in the long term with what they need. Thanks.
Sharon, I have a question about the Memphis case study. Do you know, like, do they fit more into a logic model 1 or 2 or some combination of what? Because they involve social workers.
You know, you're right. I can find that out for sure. I can find it out right after the call and let you know. I'm not exactly sure if they're more embedded or if they search out. I'll let you know.
I started talking and I was still muted. So This is our last slide, right? And we as a team of social worker, we have recommendations, but we're not here to tell you which model to pick. We really want you to think about the fact that how you define the problem determines how you find the solution. So we want to leave you with a few questions for you guys to think about when you continue on with your conversation. What problem are we trying to solve? Does the model we are considering actually address that specific problem? And then what changes do we need to make in order to address that problem without causing further harm? We're definitely discussing the true divest invest strategy problem. The deinstitutionalization that Blue spoke about in the beginning was a divest from a system that wasn't giving us the answer that we needed for folks with mental illness, and that was harmful. But now and we didn't invest in the community in the way that we were supposed to. They could have been put back in the community in a way that they could have been thriving had we been given the supports, but we didn't invest. One of the major concerns around the movement right now around reallocating and divesting into community safety in the ways that we want is that people will look at it as a way of cost savings. And that really is the wrong lens in which to look at this. This is really about building up alternative pillars of safety and not creating things that are easily cut on a chopping block. We want you to consider if you are creating something and piloting it out across the shift, the idea would be if this is successful, how do we invest more in this to get the outcome that we like? But if we don't get the support and resources, both in financial, but also in power and institutional support buy-in, you're not going to get the outcomes that we discussed. So with some models, how do we bring in a social worker and peer specialist? It's easy to get stuck on the FTEs and, oh, this is too many staff, or get shocked by the sticker price. But what am I going to have to invest in order to get what we want? And what are our community needs? We ask you to not shortchange the solution we are looking into because the sticker price is scary up front, but rather what do we really want? And then work backwards to find the solution.
Well, Nina and Heather and Jesse and Blue and Sharon and Kelly, I think you might be here somewhere listening in and contributed significantly to this work. Also, I'm aware of 2 other advocates in our community that helped with some of the background research, Axel and Grace, to put this together. So we appreciate your contributions and your expertise. So I know in scrolling through who is on the call today, we have some regular community board police attendees and some happily some new faces as well. The way we structure our discussions is there is a public comment at the end of the meeting after we get through all agenda items. So this period of time is meant for questions and discussion among our voting board members and our liaisons. I don't know if there's any other members of the elected officials in Maplewood on the call. I don't think I saw anyone. So that's what this portion of the call is for. So again, thank you guys for this. Nina, could you backtrack? I don't know if it was the last slide or the one where you had the questions up. So maybe where we could start is, I know some of the board members have been sitting here taking a lot in this very detailed and comprehensive. Thank you again. Maybe we could start with questions and then we can move from the board members and liaison before we move into more of a discussion. Roberto, did you have a question? I think you might have. Oh, you're on mute. Who is the master?
Kasha, I'm trying to unmute him.
I think yeah, who has host control? I don't have host control.
I can't force him to unmute. I can only ask him to.
I'm here now.
Okay.
I was speaking to myself and saying to you that all good things that have happened in my life have happened because there have been women around me at the time. That's true in every single case. My question to the experts is, can you tell me what percentage of people in social work are women and what percentage are male?
I don't have that data offhand, but
70,
it's definitely a female-dominated field.
Well, because to me, a social worker who's a male, especially a male of color, would be a unicorn in the sense of my experiences working in schools for 30 years. Most of the people I've dealt with in the social work field have been women, and they've been very good at it. My concern is in an environment that's more male dominated, like police enforcement, law enforcement. There seems to be a clash there of being able to engage some folks to listen to the experts as to what's best for all of us. Because my impression of people who are in crisis is the last thing I can do is compel them to do what I want them to do. Compulsion never seems to work for me when I'm working with somebody who's in crisis.
Right, yeah, because they're in fight, flight, freeze.
Law enforcement in itself defines force of behavior. And that's where a lot of these issues happen. So this number one model that you propose seems to me the one that seems to me most difficult to work through for me personally. That's why I was curious to know whether there were any figures as to the male, female numbers for people in social work. Because
yeah, so we just did a quick Google search, and it's around like 82% of women in social work.
Yeah.
But like with all things, because even with teachers, right, women, especially white women, tend to dominate the field. It's really about recruitment, and we're not talking about staffing a department of 30 people. So if we only need a few, we can find a few. We have a lot of really awesome school social work schools in the area, and I think it would just be more about us being super intentional in our hiring practices, and also figuring out where we're reaching out to, right? Like, who are we recruiting from in order to find that one or two unicorns that we may need. But yeah.
And ironically, I'm listening to a number of women talking about this issue. But thank you for that.
This is Tom Sproul. I had three questions or things to talk about. Have we asked the department, or maybe Deputy Chief Sally has a viewpoint on, how the police officers feel? Do they feel that they're successful or unsuccessful in dealing with these calls that may require a different skill set? Are they frustrated in dealing with these calls? Would they embrace this type of change? Do you have a viewpoint that you might be able to share with us?
Yeah, so Deputy Chief Sally, I would like you to weigh in here. Based on my conversations with the department, one of the biggest frustrations is the lack of a rapid response. So our officers will respond on the scene, and it can take a while. If it is a situation where a social worker needs to be there, it can, and by a while, I'm not talking a few minutes, it can take, well over an hour or so for someone to get there. And meanwhile, that person, the officer's not leaving them, and that person's getting, agitated, understandably so. Also, their training, they don't go through extensive training, and I know they're trying, but I know that's a consideration. But let me turn it to DC Sally, so I'm not speaking too much out of turn.
Aaron, you stole my thunder. That's what I was going to say. But I think all three models are better than what we have now. So it's just, depending on which model is best for us. But speaking to the officers, they would like to have a professional on scene to make some of these decisions and to de-escalate. And I believe in the long run, it will decrease the amount of complaints we might get from the public. And so it'll be great to have that kind of resource. But talking to the officers, the main concern, as Aaron stated, is getting social workers there quickly. Because a lot of times we're sitting out there for an hour, 2 hours, waiting for a social worker response.
Great, that's helpful. Second question I had was around resources, budget, staffing. So for communities who have gone about this change, I know we saw one of the slides on savings, but if you think that time is money, and there's hundreds of calls that would be diverted potentially to a social worker versus the police force, can it be self-funding in that, maybe you need 1 or 2 less police officers on the payroll for the year, if you're supplementing a lot of that work via hiring 2 social workers. Any thoughts on that aspect of things from the experts here?
Can you say that last question one more time?
Sure. The question was around, if we do add two social workers, let's just pick a number. Does that potentially relieve the need to carry the same exact amount of police officers on the force? Can you reduce the level of police officers by 2 because you have other people, other employees, other staff, consuming those calls, which can take multiple hours. From experience of other.
Yeah, I'm not sure that the models are super clear on like 2 in, 2 out, and that it's that kind of a trade-off. I think you would really have to dig into what the data is and see with like a pilot how much they take off the police plates, because I think here in New Jersey, right, police still have to respond even if they're not necessarily the lead or the point at a scene. And so maybe the social worker is leading point and the police are just securing the area like they might do at a fire call or something like that instead of engaging the individual. So I'm not sure it's quite as clear as like we add 2 social workers, we reduce 2 police. I think it would have to be something that you would pilot and then see where the workload adjusts and what it actually looks like for our community.
Okay.
In theory, yeah.
Last question
yeah.
for me, and happy to turn it to others is, when 911 is called and the police, show up on scene, they have some authority, right? They have some charge to be there. What standing does a social worker have on scene or at a situation when they get called? Like nobody has to answer the door if a social worker comes, but theoretically we answer doors for police officers when they show up. So any comments on that, on standing or what authority they would carry with them?
Well, one thing I want to point out, you do not have to answer the door if the police come to your door. You do not. It's a no. That I just want to my know your rights hat comes back on. But DC
I haven't had the
Sally,
training yet. I haven't had the training.
DC Sally, would you be able to talk a bit about to Tom's question here in terms of maybe when there's a call where the ambulance shows up and law enforcement, like how the chain of command works when you have multiple groups working together?
Right. So usually, like if it's a medical aid call, EMT responds. We respond also because we usually get there first. Our officers are on the road constantly working their patrols. So if a call comes in, we would get to the house. Sometimes we have to administer CPR before EMT gets there, or Narcan before they get there. So that's the purpose of that. And usually when the EMT gets there, once they deem it being medical, they're in charge. And our EMT is the fire department. So they're in charge of that aspect of it. But as far as I hear what you're saying about social workers responding there, like how are people going to know that what they are or what they're doing without the officer there in uniform that people are normally used to responding? That's the reason why I was kind of leaning towards Model 1. The fact that the social worker is with the officer and they're responding together, that they know that they're the reasoning for being there.
Yeah. I just wanted to add, right, Model 2 would also be responding with a first responder who's in uniform, right? So they would be responding with an EMT. I would also say that for a lot of these calls, someone has called for help, right? If it's a mental health crisis or a DV situation, it's not always somebody outside of the home who has made the call. And so if I'm calling for a family member who had a medical crisis or a behavioral health crisis, I'm probably going to answer the door. If it's the quality of life call and the individual is already like in a public space, then there's ways to engage. And I also think it's just about a PR campaign and awareness campaign to let people know this is who we are, right? PSE&G goes door to door with their vests and things on. And so people know who those workers are, who works for the sanitation department and things like that. So I think it's just going to be about having an awareness campaign, and also maybe there is some type of uniform shirt or something if they're embedded in the EMT department. But I also think you're going to find the people who don't want to answer the door for the police are also not going to answer for the social worker, but I don't think it's going to be more so, right? That they're going to answer for a social worker or other first responder less than police.
Yeah, that was a question I had, Nina, was around the communication to the communities. Like what were some of the best practices in terms of informing the community about these resources?
Yeah, I think we didn't dive into that in the research so much, but I think like any public health awareness campaign would be the same strategies: social media, flyers, posters in public places, all of that kind of stuff, town halls, workshops, reaching out to community organizations, right? Reaching out to religious institutions, the schools. It can go home in PTA flyers. Like there's a lot of different communication tools and communicating on multiple platforms at multiple times. Our community loves Facebook, so there's
Oh yeah.
one avenue.
Can we be a little more specific about the types of calls that we're contemplating having social workers respond to? I heard mention mental health calls, obviously overdoses, but also DV, which I think is a slightly different situation legally. I mean, not that I don't think that it warrants the aid of a social worker, but legally, the police, I don't think, it's my understanding, maybe DC Sally can elaborate here, but I think that they are required to investigate and there's like a mandatory arrest policy. So I don't know that the social workers can play like a primary role if they are in the moment the way that they could in some of these other cases.
Yeah, that's correct. So if there's injuries observed, there's a mandatory arrest for that. So if the person has physical injuries that we observe and we can determine who the aggressor is, that's a mandatory arrest. Also, we have restraining orders and violation of restraining orders. Violation of restraining orders are mandatory arrest. So it is important that we respond, but there are incidents where it's a verbal argument, and a social worker would be great in de-escalating that, and we support that and any assistance we can get.
Yeah, something I'll add there, right, is in domestic violence situations, I think this would be about collaboration, right? So the police department are handling the criminal aspect and dealing with the accused and the person who, perpetrated the violence. But the social worker could be there if there's children in the home, or addressing other family members, or supporting the victim with getting the medical treatment or connecting to services and knowing their rights. So you can kind of have both roles participating and engaging in the scene at the same time to offer more comprehensive and in the moment support. I've dealt a lot with domestic violence with my work in Newark, and I've had a lot of families come into the building after having an arrest the night before for their partner or something like that. And then it's my responsibility the next day to connect the woman with services and take her to the hospital and things like that, because they didn't necessarily get, it can be awkward with the police, and the police are doing the other thing in the arrest. So having the person on scene can also be very beneficial, even in domestic violence cases, even if we're not handling or managing the entire scene.
Excuse me if you've covered this.
A quick follow-up question. How does conflict of interest work with social workers? So using the DV example, if we were to go with an option where there's the follow-up services, and maybe the aggressor might need some mental health support, but you're also working with the victim potentially, or other family members. How does that play out in terms of conflict of interest?
I think it's about being very clear, like what is the relationship there, right? So I'm not necessarily the person's therapist. And so if I was the victim's therapist, then I wouldn't want to also be the perpetrator's therapist. But if I'm doing case management, I could potentially do a referral or connection to services without necessarily meeting with that individual. But it's also the point about why you would need to have more than one person in a role, right? So if I have a couple people within the department that are servicing this role, even if we're, it's 4 people to manage one position for 24/7 coverage, at minimum, then you could also have it tag team where like we break it off, because yes, it would be beneficial to have somebody who's not servicing both.
And yeah, the social worker doesn't have to, they can link different people in the domestic violence situation to different services. They're not necessarily providing the services, they're finding the right services for the individual.
I was going to chime in too, that part of what we do with domestic violence is before or after an event may have happened where the police may have been called. If we have a social worker in place, we have protocols, we have ways that we help the victims prepare. Sometimes it's a process for a person to leave an abusive relationship. And we have lots of resources that, you know, a social worker could have on site to talk to them through about some of the things they need to start thinking about, you know, making copies of their driver's license, making copies of their keys, things like that, that could potentially be something that's not a police officer's role, but could be a social worker's role with domestic violence.
I'm curious how do towns decide if it's the same number or sort of marketed as a different number, say for teens and a friend drank too much, but they don't want to call the cops because of all that involves, or other situations? Do they make a call as to whether or not there's going to be separate phone numbers for different uses? Or is it calling 911 and then with the dispatcher making that determination?
I don't know if Dean and Greg can talk about and DC Sally about the dispatch system. I know the town was looking at like an alternative to 911, and I don't think that panned out. So I don't know if you guys.
Yeah, this is Greg. I'd feel most comfortable if DC Sally addressed that, if you can.
Yeah, so we have 911, but also we have a non-emergency line that goes to the same dispatcher. I mean, like, we get all kinds of calls on a non-emergency line that are not emergencies, and we dispatch from there. So it's not top priority like a 911 call would be. Actually, in the dispatch area, when a 911 call comes in, it's a different ringtone to the phone and everything. So it's a different way of dispatching officers. So if it's a non-911 call, you call the main number, and sometimes those calls can be referred to the detective bureau or administration, and we can handle it that way.
Yeah, I'm just curious if someone could request a social worker as opposed to an officer.
That's possible if it's set up that way through our phone system.
So can I add some context here, Aaron or Kasha?
Please, Dean.
Thank you. And I'm not trying to influence the board's recommendation or however, which model you think is appropriate for our community. But I want to add some context and fill in some process, because I've been talking to our fire department and getting a better idea of how our EMS services in town work. So all of our firefighters are trained EMT. So when a call comes in to 911 to central dispatch, if it's an EMT related call, like for the various scenarios that we've covered tonight that are appropriate for social worker intervention, emotionally disturbed person, someone with a substance abuse addiction, someone who didn't take their meds and they're wandering, someone who is harming themselves, that automatically is dispatched from PD over to our fire department, and our fire department goes out to address the situation. If the situation becomes in any way a conflict, a physical conflict, it arises to some other harm, that's when fire department brings in PD for support. But usually it is the fire department, all of whom again are EMT trained, who deal with these scenarios. And we know it's been reported in public safety committee meetings that some of you have attended already. And we're going to start diving a little bit deeper into this area going forward, that we're seeing a 17% uptick in these kinds of cases, possibly due to COVID. but there are more calls for people experiencing substance abuse issues, homelessness, self-harm, suicide threats, emotionally disturbed persons. And certainly, you know, the chief of police has talked about a couple of times in a row now this year about the huge uptick in domestic violence incidents. So, you know, I know from our firefighters, if we were to go with a Model 2 approach, they would welcome the help of a social worker, because where they're limited, as they have said, and we could talk about this in public safety with them further, where they're limited is, yes, they respond, yes, they provide the medical services and intervention in that moment, but they can't go beyond that. So the following day, they can't connect that person to essential social and supportive services at the local or county level. So that person goes right back into the situation that they were in. And they do say that they see over and over again, we have about 25 incidents per month. And a large majority of those incidents are the same people that we see over and over again, which means that they're not receiving the help that they need. Substance abuse, addiction, treatment, whatever it is. So, so that's interesting, right? So maybe, you know, a hybrid approach would be really helpful. Someone who works with PD and someone who works with EMT, with our fire department, and is housed under public health. I don't know. We can look at that. But, you know, as we think about what are the issues that we're trying to address, what are the questions, as Nina said in the beginning when she was framing it, what is the question that we're trying to answer? We should think about this. This is where our need is. And this is what our structure is here. This is how we do EMT in Maplewood right now.
Thank you, Dean, for that context. Do other board members or our liaison members have questions for our panel of social work experts?
Susan or Michael, Piper, any of you have any questions or thoughts you want to share?
Nope, just taking it all in. Thank you.
Am I missing anybody? The group is so big. To tick off all the bodies. Okay.
This is a just general question, but probably for later, like once we get to implementing, would love to hear more about the metrics for you guys. So like how will we do the KPIs on whether it's working and cost benefit for each one? But that's probably for later once we select a model. Would like to get your advice there.
No, I agree with you. There's the philosophical, and then for people like you and me, and I think if a number of us other folks on the line, like how do we operationalize this?
Yeah, exactly.
Exactly.
And at some point, like whatever we pick, at some point it's our duty really, I think, to justify it, to say like it's actually working, it's having an impact, this is the return on the investment. So I just want to be prepared with solid metrics for that.
Exactly.
Absolutely.
We decided not to go into that today because we felt we're doing like, that's like another, we didn't want to do too many things.
Yeah, but that's when we bring Sharon back in. We're like, hey, Sharon, we reel her back into the conversation.
So I think
she's willing.
Because
can I take a minute?
Oh yeah, Roberto, sure. Sorry.
Because I heard two different things and maybe I misheard. First, I heard that the police show up first. Then I heard that fire department and EMT show up first. So I'm a little confused about that. Second of all, if the problem is to reduce negative interaction between police and community, if the goal is to provide a safer environment, then I would need some clarity as to whether it is police that show up first and are unable to apply their skills appropriately because of the requirement. You know, I have an electrician who can't go on the roof, and I have a carpenter who can't do water lines. So I'm confused right now as to what the real problem is that we're talking about. Is it police interaction with people who have crises that causes our community to be less safe, or is it something else?
I think it's to answer your second question, and then I'd like to turn it to DC Sally on the who responds when a call comes in, who actually responds on the scene and who's required to be there, who's recommended to be there. In terms of what I see, and this I think is more of a discussion point, I see the issue or what we're trying to solve for is reducing the trauma that may come from repeat police interaction in situations where somebody may be in crisis. And the other bit is to, larger than that, as a community, to think more holistically on how we can help our community members who may be having a mental health challenge or emotional health challenge get health resources, like stop stigmatizing mental health as something other and actually treat it like a health issue, just as similar as we would treat a heart attack or a broken bone or something like that, like actually proactively trying to provide resources in the community to help people. So I see it as both. But DC Sally, but that's my opinion. But DC Sally, when a 911 call comes in and dispatch gets it, and it's an EMT call, who's actually driving to that particular house?
Yeah, so since I've been here 19 years, we respond to all those calls. We transfer the call over to EMT. They also respond, but we usually get there first because we are already out there. So if we have to administer any type of medical aid such as CPR, we would do that. But once EMT, the fire department gets there, they take care of the scene. So that's unless something changed recently.
Okay, so if that is accurate, and I believe it is so, then what I'm hearing is that when the police show up, it creates a less safe environment than before, in the sense that
I don't think it's a safety issue. Is we get there faster issue. So if it's something that we can, respond to or make a determination before the EMT gets there, then we will do that.
Right. No, I understand that piece, and I understand the reason why the police will get there first. My question then becomes to the concern that I heard, I'm hearing this with my ears, that when police interact in those situations, it seems to create a tenuous environment where
I don't believe that to be true. There might be situations where we have to transport an EDP or somebody and they become combative, and that's where use of force comes in at. But for most medical aid calls, there's not a escalation or anything to that effect.
So when our police go out, do they see themselves as law enforcement or peace officers?
Well, we just by nature in our uniform, we're seen as law enforcement officers, but they're there for care. They're not there to search the house or look for. It's just to take care of that person that's there that moment.
Okay, thank you.
Yeah.
I'm not sure everybody agrees with what I just heard, by the way.
The thing that I'll add to that is that it's about who is like leading the scene, right? So police are able to get there first. But if it's a scene where police are like, say it's a person who's agitated and just like pacing back and forth outside, the police attempt to engage, the person clearly doesn't want to engage with police. Police can secure the scene and like maintain safety in the area, but are waiting for the mental health professional to come and actually engage. And so that would be different than if there isn't a mental health option to come and engage. What is the police officer doing? They're trying to manage and control the scene by engaging the individual. So I think it's just about not necessarily who gets there first, but like what is the role of each department in these types of calls, and in what ways could social workers augment or support police work, and how could police also support the work of the social worker, and how can we collaborate and work together to maintain safety for everyone?
Right.
But in defense of that police officer, if I get there first, my primary role is to control the environment.
That's true. That's true.
So
But
my primary role is to control the
about,
environment, which is to control the individuals.
yeah,
But we
but I
have
thought
an educated individual out there who is not going to listen to me, who is trying to apply the law.
right. But your first example, I thought you were talking about a regular medical aid call. Somebody's sick. We respond to those calls as well. Somebody has a broken leg. Somebody has, has to go to the hospital. We respond to those calls. We're not there to control the scene. We're there to take care of the patient.
Yeah, I was talking in the sense of where there's a need for social work intervention.
Okay, yeah. Well, social work intervention, we have plenty of cases like that. We watch many body cam videos of our officers responding to these scenes, and the problem we're having is getting the social worker out there in a timely manner. So I actually watched a body cam video with Aaron one time where the officer was sitting out there for about an hour and a half waiting for Claremont to send somebody. So that's the issue we're having. When the officers get there, they're trying to de-escalate. They're doing the right thing. It's just that the time gap of getting a social worker out there to make a determination if this person needs to go to the hospital or they can be released is our issue we're having.
Yeah, I have to say, it was very distressing to the video I watched with DC Sally, the amount of time that ticked before someone got there. And the challenge, so what we have right now in our community is we don't have a social worker here. We have one through the senior services, but not one that's connected to the police department or the fire department or to EMTs. And so they're based out of, where's Claremont? Down in Belleville or Bellevue or Belleville. So it takes a while for someone to get here if they need a social worker.
And then if you take all of the initial, from the very beginning of this deck about trauma and compounding trauma and interactions with the police for, certain populations, that, those interactions as positive and as perfect an officer might be in a specific interaction, it may not matter. Just the presence of an officer may compound that trauma just because of the history that person may have experienced with police and because of our society at large. So it's
Do we have any kind of analysis of in our community and how many cases we feel it would be or would have been appropriate in, say, the last year or last 2 years to have a social worker be the one responding to the call or accompanying an officer to the call versus the police only response?
Yeah, so we shared some data at the very beginning of this for 2019. Now it's the initial look is fairly cursory because a lot of these calls aren't coded in a way that makes it easy for us to really peel it apart. So I think, it misrepresents and frankly, most likely underestimates the number of calls. But what we do see is that there's an over-indexing on domestic violence, EDPs, and wellness checks, neighbor wellness checks.
And the judgment is that should be something where it would be more appropriately responded to by either a social worker alone or a social worker with an officer.
And that's the conversation that we're having today, right?
Yep. Thank you.
So do we want to, we're still recording. I feel like we've asked all of our questions. Are there, because I want to, last meeting, we had a discussion about, we would record the presentation, but discussion and deliberation would be just an open
I'll stop
meeting.
the recording now.
Yeah.
I have one more question, if that's all right.
Oh, Piper. Is that you, Piper? Piper, you have a question, right?
Yeah, I do. I'm sorry. To Deputy Mayor Jaffis's point earlier about a hybrid, have we seen that implemented anywhere nationally? Or is it just those two options that we've seen, the first two?
Nina and Jesse, and what have you guys seen in terms of a hybrid of social worker in police and also, I guess, a hybrid of options 1 and 2?
Yeah, so I think from what we've seen, a lot of communities, I think, are going like one or the other and not necessarily duplicating, because if you have someone, what I would see as a hybrid that would be more effective would be like 2 and 3, where you have a community preventative social worker and then someone also embedded in EMT. Having a social worker embedded in 2 first responder units might end up being duplicative, if that's the word.
But Piper, that's a really important point that to bring up, which is that it's not that we have to recommend and choose one of these necessarily. Like if we wanted to go to the township committee and say like we think, you know, ideally a hybrid model of 2 and 3 would be best, or 1 and 3, something like that, and then we should be, or that like you should explore these 2 as you sort of go down the operationalized path. I think is a really important point.
So thank you, Piper. Thank you. So Akasha, you'll turn the